I'd like to welcome you to this session of oncoplastic surgery. And we are very, very lucky to have an amazing group of people who will be lecturing today. Dr. Tibor Kovacs is currently an honorary professor, and he is the head of the breast unit in GI Breast Institute in Shanghai, China. Dr. Virgilio Sacchini is an attending breast surgeon at Memorial Sloan Kettering. Dr. Cicero Urban is also an attending breast surgeon in Brazil, Curitiba. As you realize, there's a lot of expertise in this team. And myself, I'm an attending surgeon and a professor of surgery at Cornell University, and I work at the Memorial Sloan Kettering Cancer Center. What I'd like to do today is we have a session of that's going to go for 2.5 hours. Each presentation will be 30 minutes. And we will have a Q&A question at the end as a panelist. But because it's very late for Dr. Kovacs, we're going to have 5-minute Q&A session at the end of his session. He'll be going first. And I would like to thank Dr. Tibor Kovacs for joining us, even at the time of his vacation. The topic that we'll be covering would be donut mastopexy. That would be by Dr. Kovacs. Then I will be talking about crescent or dome mastopexy. Dr. Sacchini will be talking about nipple-sparing mastectomy, and Dr. Cicero Urban will talk about reduction mammoplasty. Dr. Kovacs, it's all yours.
Dear colleagues, dear organizers, Professor El-Tamel, thank you very much for the introduction, and it is a great pleasure to be with you on this course. What I'm going to talk to you about today is one of the central quadrant techniques, which is the round block. And before we go into the details of the technique itself, I would like to go through a few issues regarding different level 1 oncoplastic techniques, which you all know that level 1 oncoplastic techniques, they mean an up to 20% volume excision from the breast, but as you know, even smaller resection can cause significant breast deformity and indentations. Therefore, we have to be careful how the breast is manipulated and managed during these resectional surgeries. The most sensitive quadrants are the upper inner quadrants and also the lower pole 6 o'clock position lesions. We always have to assess the breast glandularity, breast density, and there are certain selection criteria what we can use in order to select the different techniques. One of the selection criteria is based on the Barrett's density scoring. The more fatty, less dense breasts are more suitable for the level 2, more complex oncoplastic techniques. The dense breasts, the type C and D breasts, are more suitable to the dual plane undermining techniques, the level 1 techniques, which are the best suitable for these. I also remind you that the breast is contained between 2 layers of the superficial fascia, and these are the planes of dissection, what we use quite often, not only in skin nipple sparing mastectomies, but also in major oncoplastic techniques. The planes of dissection, they follow usually the superficial fascia layer and not the skin itself. This is why you can have different thickness of skin and dermoglandular flaps, which is quite important in preserving the blood supply to the skin flaps. Also, during nipple sparing mastectomies, the plane of dissection is the same as quite often is used in level 1 oncoplastic techniques, which is just below the deep dermis and at the level of the superficial fascia. One of the most often used techniques in any oncoplastic technique is the extensive deepitalization, what we use. And for example, in the round block technique is the periareolar deepitalization is a quite significant part of the surgery, and we have to be sure that we do it the correct way. For deepitalization, the most often used instruments and most convenient instruments are the Baron handles and Baron handle scalpels and Edson forceps, which make the procedure much easier. This is just an area of deepitalization, what we use in inferior pedicle mammoplasties for the nipple complex blood supply. Nipple anatomy, no ductal elements in the areola, and this is really important to remember that there are no ducts in the areola. The central ducts are going up to the skin level, and the nipple should be partially inverted or everted when we want to dissect properly the nipple area in order to achieve complete excision of the duct. The blood supply to the nipple complex comes from a superomedial pedicle, as you can see on this anatomical cadaver model, and it's quite important to try to preserve the blood supply to the nipple complex to avoid any necrosis of the nipple area. The innervation of the NAC is given by the anterior and lateral cutaneous branches of the fourth intercostal nerves. Again, important to preserve. Level 1 oncoplastic techniques with after wide excisions from the skin to the muscle area, we do a dual plane undermining at the level of the pectoralis fascia and also at the level of the superficial fascia in order to mobilize the breast glandular tissue and to close the breast gland in the area where the gap in the breast has been performed. The skin undermining can be performed with scalpels or with a diathermy knife, and it is quite extensive around the skin opening on the flanking quadrants of the breast. The nipple complex undermining, sometimes it is possible to do that, and the nipple is going to be fed and the blood supply preserved on the subdermal plexus for the nipple complex, and this gives the possibility of moving the nipple complex further away, sometimes medialize it in lateral mammoplasties. Again, this is just an exemplification of the dual plane undermining. In any of the level 1 and central quadrant techniques, we use this technique quite often. And now about a round block mammoplasty. The donut or round block technique is used quite often in tumors which are mainly located in the upper half of the breast, but this access can be used to any quadrant of the breast. In those tumors which do not have nipple areola involvement, the breasts are of moderate ptosis, and usually this technique will lead to moderate mastopexy. Small or medium-sized tumors which are close to the nipple complex but not involving it are suitable for this technique. And this is how the two concentric lines are drawn on the breast, and I will exemplify you further on the other slides how these two concentric lines can be modified, also the external one in a different shape. Preoperative markings are always done in a sitting position, and this is quite important to remember in order to avoid any exaggerated uplift of the nipple complex. The inner line is on the outer margin or border of the areola. The outer line is usually 1 or 2 centimeters, or let's say maximum of 3 centimeters outside the inner line. And this depends on the tumor size, location, grade of ptosis, and also the nipple complex position. If the patient has a mild ptosis, the eccentric circles are, the external circle is usually an eccentric circle towards the superior aspect of the breast, and it is similar with the crescent type of incision. This is how it looks, the two eccentric circles which will lead to an uplift of the nipple complex at the end of the procedure. And usually these procedures will require also a contralateral symmetrization, which can be done at the same time or quite often as a second stage procedure if you want to make sure that all the surgical resection margins are clear on the cancer side. During the round block, there is an extensive glandular undermining after the excision, and this entails significant undermining of the dual in the two planes, which is the superficial and deep fascial plane. And the undermining goes far beyond the excisional area. So not only where the excision is performed, but also the two sides, lateral and medial, of the excisional area, in order to make sure that the glandular pillars are free enough to bring them together and to adjust them with some internal absorbable stitches. So the steps of the round block technique is, first of all, the depitalization of the eccentric or the concentric ring around the nippolaris complex. It does not entail any nippolaris complex undermining usually, and the blood supply of the nipple is perfectly preserved. The circle around the nipple can be fully excised, but more often we use the depitalization. We raise the skin flaps and undermine the skin flaps in the superficial fascia layer in corresponding to the index quadrant and also the flanking lateral and medial quadrants. There is a deeper layer, pectoralis fascia layer, undermining to mobilize the glandular tissue, and then the two advancement glandular flaps are brought together and closed in order to close the gap created in the breast by excising the tumor itself. An external purse string suture is placed in order to reduce the circumference of the depitalized area around the nippolaris complex. This is how the excised or depitalized area looks around the skin. This is the undermining, what we performed in the superficial fascia layer and advancement. The purse string suture, which we place around the nippolaris complex. On some medical photographies, this is how we mark usually the patients. As I said before, the two lines can be concentric or eccentric towards the superior aspect of the breast, depending on the grade of the ptosis and also the location of the tumor itself. The depitalized area around the nippolaris complex. The excised tumor cavity, this is where the mobilized tumor lies. The opening of the breast glandular tissue happens at the level of the external line and not at the level of the internal periareolar or paraareolar line. So the fact that we open at the level of the external circle gives a much wider access towards the breast, more space in order to remove tumors which are located even far away from the nippolaris complex towards the periphery of the breast. This is how the breast tissue is mobilized and pulled out through the incision which we create inside the breast. This is the cavity which remains after the mobilization and extensive mobilization at the superficial fascia layer. The nipple is situated somewhere here behind the fingers of the operating surgeon. As you can see, you can have excellent access towards the breast, even tumors situated quite far away from the nippolaris complex. And lighted retractors can be used in order to have better visibility and also retraction of the surrounding tissues. This is the mobilized tumor, which we mark in situ with marking stitches in order to orient the specimen three-dimensionally, and we also put clips on the specimen for specimen radiographies to make sure that at least macroscopically the margins are clear. This is how we place the clips into the cavity, into the excisional cavity to mark the cavity following the tumor removal. This is for the purpose of adjuvant radiotherapy delivery and to know exactly where the tumor bed is located. Following the clip insertion and more extensive mobilization of the glandular pillars on the lateral and medial aspect, we bring together with the glandular pillars and approximate them with absorbable internal stitches. And following this, we close the two concentric rings. First, we start with stitches which are placed opposite 12, 6, and 9 and 3 o'clock, and then opposite located stitches, and at the end with a running suture line for a deep dermal layer. And this is how we approach the closure itself. A post-operative picture where you can see that there is hardly any scarring around the nipple complex, and also quite good symmetry can be obtained if the uplift is not too excessive. This is a more recent procedure, 3 weeks after the surgery, where you can still a scar which is in healing, and there is a little bit of bruise around, but the shape of the breast is maintained. The tumor itself, it was located in the upper pole of the breast. And now I would like to share with you a video which shows the procedure itself live. This is a patient who has a tumor located at 12 o'clock position in the upper pole of the breast. The nipple complex, nipple to sternal notch distance is 22, as you can see, and she also needed a sentinel lymph node biopsy on the left side, but I'm going to show you only the breast part of the operation. As you can see, we always mark the patient's, the breast, the midline is marked, the breast meridian or the sternal notch to nipple distance is marked, and we also mark the IMF level just for orientation. All these markings are performed in a sitting position, and these are the two concentric lines, and the distance between the two, it is about 1.5 to 2 centimeters maximum for this patient. So that's the video. If anybody has any questions in the meantime, of course, you can ask. This is the injection for the sentinel lymph node biopsy procedure, which is done with dual agent localization, blue dye, and radioactive isotope. The tumor itself is marked on the skin, and it has been marked preoperatively under ultrasound guidance. Two periareolar concentric skin incisions. These incisions should not go too deep into the breast because we do not want to cut through the deep dermal layer. Depitalization of the concentric area is performed, as you can see, and the small bleeding surfaces can be coagulated, and the bleedings can be stopped if needed. And then you can see that the gland is opened at the level of the external circumference, at the level of the external incision and not the internal incision. The external circle is, of course, wider, larger, and that gives a wider access towards the breast. Skin retractors are used when the surgeon is performing the glandular mobilization and dissection in the superficial fascia plane. For the deeper layers, the lighted retractors are extremely useful. Using your own fingers, second and third fingers are extremely useful to keep and push the breast glandular tissue downwards and lift with your other finger to lift the skin itself and to create a plane of dissection with good visibility. Lighted retractor can enhance the visibility of the relatively narrow surgical field. Of course, if you manage to follow appropriately the superficial fascia plane, your bleeding is less usually, so it's some kind of relatively avascular plane of dissection. You have to mobilize the glandular tissue not only above the tumor itself, but also towards the lateral and medial aspects in order to give the surrounding breast glandular tissue sufficient mobility in order to close the gap what you create in the breast. The breast tissue is going to be excised completely down to the pectoralis fascia, This is how you can see already the tumor is mobilized and lifted into the external part of the wound. You always have to be careful not to damage the nipple complex, not to burn the nipple complex with your diathermy knife, because this is quite close. So we use a guarded and Teflon coated diathermy blade, which is quite safe from this point of view. Following the tumor excision, you do the hemostasis. You have to make sure that there are no deep bleedings from the perhaps from the deep fascial layer, and you also have to not to forget about those small clips, what you have to put and what you have to use to mark the tumor bed itself. Let me just speed up a little bit. The tumor has been completely removed. We mark the tumor and we take an X-ray of the specimen. Each hospital has their own, each department has their own marking technique. We use stitches and also clips for radiopack clips in order to be visible on our specimen X-rays. That's how the tumor itself looks, and the 3 clips as we mark the area. At this stage, the surgeon is further mobilizing at the fascial level, at the deep fascia level, the glandular tissue in order to be able to close the gland and to avoid any major indentation of the area where the tumor itself was removed from. You always have to trial how mobile the breast glandular tissue is from the 2 sides of the gap of the breast. If it is not enough, then you will further go with your mobilization technique in order to close the gap in the glandular area. Clips for the cavity marking and glandular approximation stitches placed. You do not have to put too many stitches. Usually 2-3 stitches are plenty to approximate the glandular areas. You have to be careful to avoid any skin indentation. If you put your glandular skin stitches too superficial, then you will end up with with the skin indentation. Therefore, these stitches should be placed in the deeper layers of the breast itself. And after the glandular absorbable stitches are placed, you would start with closing the superficial skin axis itself with the concentric stitches, which are first isolated stitches and then a second layer of running sutures around the nipple complex. Yeah, I think we are quite close to the end of the procedure. Yeah. So that's all what we do. On the skin, you can apply Dermabond or Steri-strips, whatever the preference and availability is. We do not use drains. This is why it is very important to do a careful hemostasis. We advise patients to wear a sports bra, a supportive bra, in order to avoid any tension on the skin. With this, I've finished my presentation, and thank you very much for your attention.
Okay, great. Thank you very much, Tibor. This is a very nice presentation. What I would like to do is have some question addressed to you. Yep. There are some questions that would be covered by the general discussion at the end, but yep, for the time being, the first question is, any need to remove the pectoralis fascia at the tumor bed if not involved?
If the tumor is not situated attached to the pectoralis fascia, I do not believe that the fascia has to be removed. As I showed on that anatomical model, the fascia is some kind of, or the breast tissue itself is inside the two fascial layers. If you manage to have clear resectional margins, or even a 1 or 2 millimeters clear margin around the tumor itself, there is no need to remove the fascia. The fascia itself is a plane of dissection which you follow when you mobilize the breast gland, but I never remove it.
Now, there's another question. There are some other questions that we will address at
Yep.
the end about how to perform oncoplastic technique in fatty breast, but we'll leave that till the end so we can have all the panelists involved.
Yeah.
What kind of suture do you use for the purse string suture? And there's a question, there's about, stretching of the nipple areola complex. So do you use a non-absorbable suture or an absorbable suture for your running suture?
Actually, I do use both, but more often the non-absorbable 3O monocular stitch what I use. We have to bear in mind that this is not necessarily a cosmetic procedure. We do not want to achieve a huge uplift or mastopexy usually, especially if you want to avoid the contralateral symmetrization. Using non-absorbable proline-based stitches that can perhaps create a more longer-lasting mastopexy. So that's the advantage of the.
Okay, and let me ask a question maybe to Chichiro. Chichiro, would you use non-absorbable suture for that, or use absorbable suture?
Now I'm doing more non-absorbable suture, more mononylon, because the scar is much better. Even if sometimes it's necessary to remove some stitches that patients return to us with some complaints of just small suture that is necessary to remove. But in terms of scar, it's much better, much. I changed the way I do the suture, the skin suture.
Now, do you do a running suture or do you do
running suture? And I let the nylon inside. I don't remove.
Okay. I also use a non-absorbable suture, and I do a running technique. But I think the trick that we all have been facing with these non-absorbable suture is the knot at the end. And what I tend to do is I tend to bury that knot as deep as I can and pull out the suture through the skin and cut it off the skin. The problem is sometimes these knots can spit through. Occasionally this happens. But I think what I found with a non-absorbable suture is it avoids the dilatation of the nipple areola complex. What do you think, Tibor?
Yeah, I agree with that. So that is a risk of the enlarged areola and the lateral size. To be honest, I think about the absorbable ones, I have not had major problems with the.
Okay, one more question is, what is a modified?
I do not think that there is any randomized control.
Oh, yeah. Okay. What is a modified donut? Hello, can you hear me?
Hello? Hello?
Yes, we can hear you very well. Can you hear me?
Yeah. Okay. Yeah, I can hear you. Yes, of course.
We have a question. What is a modified donut?
Modified donut.
I think what the person is asking, could you do an extension to the modified
question? I don't use that term, so I don't really know exactly what it is.
I think probably they're asking, could you modify it and have further extension? I think we'll address that with Chichiro, maybe. It could be modified like a V mastopexy. Probably this is what the question. Now, let me ask one more question. Is this procedure suitable for multifocal tumor or multi-site tumors? Tibor. I think we're frozen with Tibor. Yes, it is.
Yes,
it is suitable. Go ahead, Cicero.
Yes, it is suitable to resect tumors in all the quadrants, and for multiple quadrants, it's not a problem. And one trick that I use in my practice for round block, I will try to show you in this. Can you see in the upper part?
Yes, we can see it very well. Yeah.
If you do the round block like a round draw, you will have an enlargement of the nipple and areola complex in the areola. And I try to do this draw, not to do the round draw, but an oval draw. Because when you do an oval draw, because of the tension in the suture, you don't have an enlargement of the areola at the end. Because one of the complications of this technique is the enlargement of the areola, that it's not so nice after some months. This is just a little trick. The other is, of course, the suture that we were talking about a few minutes ago.
Tibor, you are muted. Could you answer the question? Yeah. Is this technique suitable for multiple tumor?
Well, I think it is, of course, because you can use it for any quadrant of the breast. So if you have if technically you have resectable tumors, let's say a multicentric breast cancer, where you can obtain clear surgical resection margins for both tumors using round block, you can resect multiple localizations, but the breast size has to be appropriate enough in order to have plenty of breast glandular tissue, what you can use perhaps to cover both areas.
But there's one question which I think you did address, but one question comes out: does this procedure cause difference in the nipple sensation?
If you operate in the area of the upper inner quadrant, and if the nerve is damaged or cut, yes, it can cause significant nipple complex sensation loss. But normally, or if this doesn't happen, then usually the innervation of the nipple complex is okay.
My experience is the most consistent nerve is the one that you have shown. Anatomically comes from the parasternal areas medially and goes to the nipple, either at the third or the fourth intercostal space. If you are operating in that site and the tumor is located on that site, invariably you will injure that nerve and will lose some sensation. There are some innervation that comes laterally and inferiorly, but most consistent one are the one that come medially. So the loss of sensation would depend on the site of the tumor. There's one more question: is there any possibility of areolar seeding from the tumor?
Areolar seeding. Well, there is no more risk than seeding anywhere else. Usually we do not cut through the tumor, so I don't think that this is a major risk as a complication or long-term negative effect of the procedure. Is the same as with any other breast conservation surgery.
Fully agree with that. Cicero? Okay.
Yes, I agree. And I just want to add something that it is important that Tibor addressed in his presentation. This technique, round block, is a very nice technique. We can remove tumors in all the quadrants. We can remove sometimes multicentric or multifocal tumors, but this is not the most aesthetical ones, because it is not for example, to do a good mastopexy or a good aesthetic. This is for reconstruction. This is a very interesting point, because when you want to do a more aesthetical surgery, it is necessary to maybe do a different kind of oncoplastic surgery. This is nice. It works well, but if you have a patient that has a big breast and she wants to have a big reduction, this is not for this technique.
Yes.
Okay.
I think that's a very good point, and here comes also patient choice in, because it depends, you know, what the patient would like to achieve with the surgery itself. Because sometimes some of the, you know, we think that we want, you know, it's a nice procedure for perhaps reduction mammoplasty or something similar, which is a more extensive surgery, but the patient does not really want to have major asymmetry, or they do not want to have you know, contralateral surgery needed. And the other thing what also comes in, of course, the costs of these procedures. It depends on which of the sectors you work, whether it's public sector or not. In the UK, I was very lucky because we could do everything what we wanted. The NHS was easily paying for it, but in the private sector is very different. And I think that has to be also agreed with the patients, what their expectations are from the procedure itself.
And there is one question here, Mahmoud. Is this technique have a good result for grade 3 or 4 gynecomastia?
Well,
yes, it is.
I know it is, but I wanted to keep it till the end. Just I
Oh,
wanted
okay,
to,
sorry.
yeah, I just want to move ahead because of the time constraint.
Okay.
So I think I'll be giving my presentation now, and then we will have a lot of these questions addressed at the end of the session. So let me share my screen. I'm going to try to do like Tibor, have a quick presentation, have actually extensive presentation, then give you a video, and then we'll take it from that point. First, I'd like to state that I have no disclosures. And what I would like to do is talk about preoperative planning, the incision, the resection, the closure of the defect, the skin closure. Then I'll have some modification and extension of the crescent or dome mastopexy, and then I'll have the video presentation. So let's talk a bit about the preoperative marking. I think Tibor went through that, but I'd like to do this step by step. Usually we do the preoperative marking in the patient in the sitting or standing position. This is the patient in the sitting or standing position. The first thing you could see, we have the jugular notch right here. We draw a line along the clavicle from the jugular notch all the way to the mid clavicle, which is usually 5 to 7 centimeters. The taller the patient, the wider this line and the wider the chest. You drop a line from the mid clavicular line to the nipple. This is what we call is the nipple line. You cannot elevate the nipple except along that nipple line. If you elevate it medially or laterally, you will end up with a very poor cosmetic result. This is an extremely important point to keep in mind. The next step, you draw around the areola, and usually we try not to go beyond 50% of the areola, and then you draw the other line, which is the second line of the crescent. Now, the height of the crescent is usually between 1 to 3 centimeters. This technique is not usually to do a major mastopexy. This is limited for exposure, and it will elevate the nipple areola a little bit. As you previously heard, we do not use those techniques to have a major mastopexy. Now, remember that we don't want to elevate the nipple too much. And the best way to elevate the nipple is to elevate it to what we call the Pitangui line. This Pitangui line was described by Dr. Pitangui from Brazil. You put your hand under the breast and you feel for the inframammary line, as you could see it, and you don't want to elevate the nipple above that line. Now, if there's a major distance from the nipple line where the nipple lies and the Pitangui point, maybe you should not do this technique if you want to elevate it. Remember, you could elevate it just a little bit, keep it below the Pitangui point, but you should never go above the Pitangui point because you end up having a very poor cosmetic result. Now, let me talk about the indication and the skin incision. I usually limit the crescent or dome mastopexy to lesions that are behind the areola or in the upper quadrant. I try not to do it. I've done it few times for lesions that are 4 or 8 o'clock, but I usually limit it from 3 to 9 o'clock and for lesions that are central in the breast. Usually you drew the incision as I showed you. You could take the skin as part of the resection if the tumor is very close under the skin and you want to take some of the subcutaneous tissue. Most of the time we end up de-epithelializing the skin to have a better access. Now, I usually make the incision at the upper level as Dr. Kovacs has shown you. We make the incision and I leave a little bit of dermis on the upper end. It would help me to close the skin. Now here I'm showing you where we're resecting the skin with part of the tumor, particularly when the tumor is close to the nipple areola complex. And this is an example of a patient where we took the skin, the tumor was somewhere here. We had to take and shave the nipple areola, and we took a margin from the nipple areola to make sure it's negative. Now, the flaps, there are different ways of raising the flap. And I usually use the glandular plane, or you could use the superficial facial plane as Dr. Tibors has shown you. For superficial tumor, you may have to excise the underlying subcutaneous tissue, and this is when I tend to use the superficial facial plane. You have to preserve the blood supply to the nipple areola complex and the overlying skin. So you have to be well cognizant of the blood supply of the overlying skin and the nipple areola complex. Now here, I will show you the two different glandular plane and the superficial facial plane. The superficial facial plane is way up under the skin, and this is usually the plane that we use for the mastectomy plane. If you have a tumor that is quite superficial and you want to take some subareolar tissue, you could raise the flap at that plane, or you could use the glandular plane, which is the lumpectomy plane. And let's say your tumor is here, you go up to the superficial facial plane, then you go back to the glandular plane. Now remember, let's give you an example. This is a tumor that is here. You raise the flap at the glandular plane and you do the resection. Sometimes if the tumor here, you may have to raise the flap at that level, also around the nipple areola complex. Please remember that the glandular plane is not a flat plane. This is Sir Astley Cooper drawing of the breast. They are amazing drawings. How real this drawing is. It's just amazing how a good anatomist Sir Astley Cooper was. You could see it's like the surface of the moon. So you have to cut, if you're going to go at the glandular level, you have to cut through those Cooper's ligament. Now, this is an MRI visualization of the glandular plane, and you will have to cut through those glandular, Cooper's ligament if you want to go through the glandular plane. Now, you raise the flap till you have a very good exposure of the tumor. Now, Dr. Kovacs have shown you how to raise the flap. Here, I'm showing you a lateral incision. You really try to raise the flap so you could have a very good circumferential exposure, not only to resect the tumor, but also that will facilitate the closure of the defect later. Now, for the closure of the defect, once you have raised the skin flap, you have resected the tumor, and you do use your best surgical oncology techniques to resect the tumor. You want to achieve negative margins. Now, nowadays, you don't need to have a 5 millimeter or 1 centimeter margin. No ink on tumor is more than sufficient. Now, we usually take a measurement for probably 0.5 centimeter to 1 centimeter beyond the palpable area. We review all the images that are available to see and include all the microcalcification. Sometimes we use bracketing techniques if you're using seed localization or wire localization to include all the suspicious findings on the mammogram or the sonogram. We do not perform MRI routinely on all these patients. So you don't really need to have an MRI on these patients. We do MRI when needed. Please remember that you could, in patients that have large tumor, we very frequently resort to neoadjuvant therapy to decrease the size of the tumor. Most of the time we use neoadjuvant chemotherapy, but you could use neoadjuvant endocrine therapy in ERPR positive, HER2 negative tumor that do not need chemotherapy when their oncotype is low. Once you have raised those flaps, we raised the glandular at the pectoralis fascia. We try to avoid getting into the fascia. However, sometimes you get into it, it's not a big deal. My feeling is if you get into the fascia, you may cause pain. You do not need to take the pectoralis fascia. That principle of resecting from the skin down to the fascia is way gone. And this is what we call the Holstadian principle. That erasing the flap would allow you to close the breast tissue better. Now, the closure of the defect, how do you close the breast? You could use different technique to close the defect. You could use and I'm usually categorize them into different technique to teach them better. You could do a transverse closure or a radial closure. And I'll show you these different techniques. In the video, I'm going to use the radial closure, but I'll discuss here the other different closures. You could use a triangular closure, which is really very helpful to allow you to gauge the level of elevation of the nipple areola complex, or you could do a purse string suture. Now, this is a patient that has a tumor here. As you could see, we have elevated the flap. We resected the tumor, we elevated the glandular level, and then you close the defect transversely, which means along a transverse line. Now, the triangular closure, I'm going to show you in the video the radial closure, so I'm not going to talk about it. But anyway, what we mean, you go along the radius of the breast, either around the 12 o'clock, 1 o'clock, or 2 o'clock. The triangular closure is basically a combination of the transverse and radial closure. You put the triangular suture. This is the nipple. This is the head of the patient. The tumor is around 12 o'clock. You put the triangular suture, and when you tighten the suture, you end up having something that looks like a triangle. For those who like cars, I call it the Mercedes repair. And then you close the defect along those triangles. How does it help you gauge the elevation of the nipple areola complex? Let's say the nipple here, this is your defect. And if you want to elevate the nipple that much, you don't want to elevate it beyond that, this is where you put your sutures. And then when you tighten that suture, the point C will come to A and B, and you can control the elevation. If you want a lower elevation of the nipple areola complex, only that much, you put your ABC suture along those levels. And when you tighten that suture, you bring it only to this level and you close the rest of the defect radially here. And here you would close it transversely. The purse string suture, for those of you who have been trained at the open surgical technique era where they did their appendectomy, this is how we used to close the stump of the appendix. And I designed that technique with the dunking the appendectomy stump. You do those purse string suture and you tighten them, and you tighten completely the closure of the defect. Now, the skin closure, please remember that the skin is, this incision is much shorter than this incision. And you're going to have a discrepancy in the defect. So you have to create a way of closing that defect to correct for that discrepancy. So to correct the size discrepancy, what we do, I take a transverse suture at the upper skin flap, and I do a vertical suture at the lower edge. And these look like that. This is a vertical suture, and this is a transverse suture. You end up having what we call triangular suture, all of these. And I'll show you that technique in the video. Now, this technique could be done with skin extension, and we call these the modification of the dome mastopexy. You could, the most commonly previously described is what we call the bilateral extension. These have been called as the omega sign by the Institut Gustave Roussy, or the Batwing by Mel Silverstein. Mike Dixon made a lot of fun of Mel Silverstein, calling it the Batwing as a scary technique. So we stopped calling it as a Batwing. But anyway, whatever you want to call it, it's bilateral triangular extension. There are lateral extension, and there could be medial extension. This is an example when you try to do the Batwings. You do one circumareolar incision, a parallel circumareolar incision, and two triangular on each end. Remember, when you close this technique, this goes straight up here, and this comes up to here. These are exactly the same distance. The lateral extension is when you have a tumor laterally, and you resect the overlying skin, and you de-epithelialize the skin. Again, there's no discrepancy in the size of the closure here, because this point is going to go to this point, and this would close nicely, and you would elevate the nipple along the nipple line. This is an example of multifocal tumor that are present. I'm not recommending this technique, but this patient refused categorically to have a mastectomy and did not want to have a major change in her breast. So we gave her neoadjuvant chemotherapy. She had two separate tumors. She actually had 4 tumors. The distance between the first and the widest distance was approximately 6 centimeters. This is on the MRI prior to neoadjuvant chemotherapy. This is when we wanted to mark after neoadjuvant chemotherapy. We put 4 seeds into that patient. And here you could see her with the mammogram prior to the surgical intervention. This is prior when we localized with 4 seeds. This is the ML view, and this is a CC view. And this is where she had the tumor, multifocal tumor. This is the specimen that we have removed, 12 by 10 by 5 centimeter. And this is from another example of another patient where we resected the skin incision. You could see the closure of the glandular defect. This area was de-epithelialized, and we will elevate the nipple along the nipple line. And this is how the patient looks like after radiation therapy 7 months down the road. She had a significant hyperpigmentation. This hyperpigmentation was lost. This is a scar that she had way before it's a keloid. And you could see the radiation therapy avoided the keloid on the skin incision. She has a beautiful cosmetic result. The hyperpigmentation was completely gone 2 to 3 years, or actually should not say completely gone, faded away with time. Still, the result is very acceptable. You could have a medial extension. This is another example of a medial extension. You de-epithelialize the skin and you resect the skin overlying it. You close the skin defect the way you see it right here. And this is an example how the patient looks like post-operatively. So let me shift gear and show you the video. And I will share the video now with you. And this is a video that I've done with one of my fellows. I will stop it every now and then to make some comments. My fellow was Damien McCarty. We presented this video at the American Society of Breast Surgeons. And here we go.
Will demonstrate the steps involved in performing a dome mastopexy, a versatile and easy to learn oncoplastic procedure.
Are you seeing the video?
This video will demonstrate the steps involved in performing a dome mastopexy, a versatile and easy to learn oncoplastic procedure. The case is of a 50-year-old lady with a screen-detected cancer in the 12 o'clock axis of the left breast. We will outline the principles of preoperative marking, the aspects of closure comprising mobilization of the glandular tissue followed by repair of the lumpectomy defect, and skin closure to allow correct nipple alignment.
I just want to make sure that you guys are seeing the video. Are you seeing my video?
Yes, we can see it. Yes.
Perfect.
The patient is marked preoperatively as illustrated while in the standing position. The skin incision should be limited to 50% of the circumference of the areola. It is important to limit the width of the ellipse to no greater than 3 centimeters. If it is felt that a greater degree of elevation of the nipple areola complex is required, an alternative mastopexy procedure may be more appropriate.
Now, as you realize, we perform these techniques under local anesthesia with sedation. We don't give the patient general anesthesia. That's why you saw me injecting the lidocaine.
The skin can be taken as a composite en bloc resection if the tumor is in close proximity to the skin. Otherwise, the incision can be deepithelialized for the purpose of exposure. This maintains a subdermal layer that can be incorporated in the final closure. The lumpectomy does not need to follow the shape of this overlying skin incision.
We use in these localizing technique a seed localization, but this could be done with a wire localization if you do not perform seed localization.
A dome mastopexy is ideal for lesions in the upper quadrants of the breast. At this point, the skin and subcutaneous tissue are elevated off the breast circumferentially at the glandular level. This lumpectomy plane is deeper than the mastectomy plane and preserves subcutaneous tissue.
Now, as you have seen with Dr. Tibor Kovacs, we like to use our finger to retract the glandular tissue. This is very helpful. You could use your forceps. If you stay in that plane, the glandular plane, you have very few bleeding, but sometimes you face that bleeding and you have to cauterize them. I usually raise the flap with a electrocautery. It is very helpful. And I have a suction attached to my electrocautery. That's why you don't have fumes while you're raising the flap.
When this plane has been developed caudal to the lesion as detected by the probe, the area of maximal signal can be marked with a suture. Now, with adequate circumferential exposure of the radioiodine seed localized lesion, a formal oncologic resection can proceed. The specimen is sent for X-ray and cavity shaved margins, then taken to complete the resection.
We at our center prefer the cavity shaved margin. However, you do your margins, whatever you feel is most convenient to you. We take the tumor out and then we take extra margin. I personally prefer to take a wider margin and shave the margin off the specimen. Like that, I can guarantee that I have the totality of the margin. However, you could shave the margin from the cavity itself.
Next step is to elevate the breast tissue off the pectoralis fascia in the plane of the retromammary space, taking care not to incise the fascia. This allows mobility of the breast tissue over the chest wall to facilitate repair of the defect. The cavity is then clipped and irrigated and hemostasis secured.
We strongly recommend that you clip that cavity. This is very important for your radiation oncology colleagues that would allow them to identify the cavity and boost it if need be.
The defect is evaluated for closure and is approximated along the most convenient axis. In this case, the breast tissue is repaired in a radial fashion in the 12 o'clock axis. Breast tissue is approximated at multiple levels, starting with the deep layers with a 2-ovicral suture. An alternative defect closure method here would be a triangular closure, which can help to control the extent of nipple areola complex elevation.
And you could see here, we are closing the defect radially along the 12 o'clock axis.
Documentation of the type of closure in the procedure note is crucial in case a further procedure is required to excise a pathologically involved margin. If puckering of the skin is...
This is an important point. You need to document how you closed the margin, because if you have to go back, you will resect the specific margin. I have interrupted the video here, but I just want to show you, once you have closed the defect, you may have indentation, and you need to release those indentation if you have not raised enough of the skin. And I will show you how to do that.
Noted upon closure of the deep layers, now is the time to release extra skin to allow restoration of the contour of the breast. The next layer of closure is the layer that was initially de-epithelialized.
I just want to say that I do approximate the fatty tissue. If you have raised it at the glandular plane, that's very important. And there's a layer, deep dermal layer, that you need to close also. This is very important to prevent widening of the scar. This is
To negotiate the unequal length of the skin incisions, when placing the deep dermal sutures, take vertical bites on the inferior edge, followed by transverse bites on the superior edge.
You could see me putting these transverse suture now on the upper edge.
The triangular nature of these sutures is such that the apex is at the areola edge and the base of the triangle at the upper surface. Finally, the skin is closed with a 4-monocrystal subcutaneous suture. On final pathology, the surgical margins were clear with a T1b primary tumor.
Now you realize that there's a minimal elevation of the nipple areola complex complete to the side, and she has a beautiful cosmetic result.
To illustrate the long-term outcome, these images are 30 months post-operatively from a similar patient who had a dome mastopexy.
In summary, you draw the dome above the nipple areola complex, centered on the nipple line in the upright position. You de-epithelialize or excise the skin of the dome extension as needed. You raise the flap at the glandular level, or if you want at the superficial facial plane, depending on the depth of the tumor. You use your safest oncologic resection of the tumor. Please remember that this is an oncologic procedure first, and then the plastic part is later. And you mobilize the breast tissue to close the defect. And you close the skin with triangular dermal suture to correct the size discrepancy. I will stop here. And this is a picture of the central part now that is blooming with the spring. And I will turn the podium to Dr. Virgilio Sacchini, who's going to talk about nipple-sparing mastectomy. And then Dr. Cicero Orban will go after that. Thank you.
It's a really special pleasure for me to present at the 4th International Multidisciplinary Breast Conference in Dubai, presenting our experience, the Memorial Sloan Kettering Cancer Center experience on nipple-sparing mastectomy, a procedure that is increasing in all the world. We are doing more and more nipple-sparing mastectomies in our institution for risk reduction surgery as well as for therapeutical surgery, nipple-sparing mastectomy for cancer. And we have now more than 1,600 nipple-sparing mastectomies in our database. And the reason why we are doing more and more nipple-sparing mastectomies is that the result in terms of quality of life for the patient is better psychosocial well-being, better sexual well-being. And the patients are asking more and more for this procedure. When we started and when we are doing even now this procedure, we have two priorities. The first is the oncologic safety. We don't want to leave any cancer in case of this procedure for cancer, and we don't want to leave a residual breast tissue or remove as much as possible in a risk reduction surgery, because this tissue may be the source of a cancer for high-risk patients. And in the meantime, we need to be safe in terms of risk of complications, especially necrosis of the mastectomy flaps, nipple and areola necrosis. This may delay the wound healing, delay possible treatment, and sometimes even failure of the reconstruction, the loss of the implant. Our priority is, of course, to remove all the breast tissue, to core the nipple, to leave a very thin nipple and areola flap in order to reduce the risk of residual ducts, residual cancer, residual breast tissue. And unfortunately, we are seeing more and more nipple-sparing mastectomies perform not taking into account the possible residual breast tissue. This is a case in which the surgeon did a nipple-sparing mastectomy. The patient had 3 relapse. We had to do the total mastectomy, and you can see how much residual breast tissue was left behind after the initial procedure. We are doing more and more nipple-sparing mastectomies in young women, BRCA positive. They get pregnant later on, and after the delivery, they may have a production of the milk because a lot of breast tissue is left behind after this procedure. And of course, we prefer to do an additional surgery to remove this residual breast tissue in this very high risk women for breast cancer. Of course, if we more tissue we remove, more retroareolar tissue we remove, more thin skin flap we do, and more risky the risk of complications. But if you look at meta-analysis with the modern nipple-sparing mastectomy, in which the intent is to remove all the breast tissue, you can see in a very large number of procedures, more than 12,000, that the risk of complications is not so high, and the real risk of nipple necrosis is 5.9%, so quite acceptable. Of course, you can have some complications that at the end of the story, they are not so important, like sort of partial disabilitation, epidermolysis of the skin that is after 2 weeks completely restored. The real complications are when you have at least 2 out of 3 areola and nipple necrosis, and you may lose part of the nipple and areola, or of course total necrosis of the nipple and areola, in which you may need to excise the nipple and areola. But overall, these complications are not so high, 1.3%, about 2% in the partial necrosis of the nipple and areola. There are risk factors, of course, for this risk of complications: the body mass index, smoking habit, prior radiation therapy, sometimes periareolar incision, the inferolateral incision may increase the risk of these complications. An important determinant of the risk of complication is the experience that you have with the procedure. And you can see the difference at the beginning that we had in terms of complications, and after some learning experience, how the risk was lower. And I'm speaking about the most important complications like the partial necrosis and the total necrosis. So experience is very important in this type of surgery. When you have good experience, when you are in an environment where you do a lot of nipple-sparing mastectomies, you can see that there is no important difference in the risk of complications for not nipple-sparing mastectomy, skin saving mastectomy with respect to nipple-sparing mastectomy. And this is the result of a study that we did in our own institution. The risk is, of course, due to the thin flaps, but also to other habits, other procedures. And when you pull too much the skin, when you do skin flaps, you can really destroy the little subcutaneous vessel. So when you do nipple-sparing mastectomy, don't retract too much. Another technique to reduce the risk of complications is to use the cold blade, the scissors, when you do your retroareolar dissection. Don't use the cautery, because the cautery can destroy with the thermal damage the epidermal and subcutaneous skin vessels, nipple and areola vessels. So we do our dissection, flap dissection with the cautery, and as you can see over here, and we try to arrive close to the nipple and areola. Then we inject some solution to create a good plane. I will show you better after. And then we dissect the retroareolar ducts with the scissors. May bleed a little, but you can see that we are very careful in dissecting the retroareolar ducts with the medicine bound, and that are less traumatic than the cautery on the retroareolar small vessels. We do some little hemostasis, and we continue to perform our dissection of the retroareolar ducts with the scissor. We check, of course, the flap, how thin is the flap, and of course we need to remove all the milk retroareolar ducts from the nipple and areola. At a certain point, you put your retractor and you continue. You need to pay extremely attention not to injure the nipple and areola, to make a hole in the nipple and areola with your scissors. So you need to do a very careful dissection of the nipple and areola, and you can see that the nipple is really core, and all the retroareolar ducts are removed. And you know, sometimes you may enter with your scissor, divaricate your scissor to create a better plane. In this case, this nipple sparing mastectomy was done for cancer, and you can see that we cut some retroareolar tissue, sent to pathology to be sure that the frozen, and ask for the frozen section to exclude the presence of a cancer. Frozen section may have 5% negative result, so in 5% the final pathology may show presence of cancer in the retroareolar ducts, and we need to go back and remove the nipple and areola. Another important thing that you will need to take into consideration when we do nipple sparing mastectomy is to save as much as possible the skin vessels. And one important bundle is the perforator going from the second intercostal space to the breast, but also to the skin and to the nipple and areola. So identifying this perforator that is usually at the second intercostal space is very important, and try to save it. Sometimes you can identify your perforator with the echo Doppler and mark this perforator. At the MRI, this perforator is very, very visible, and you can mark on the skin the perforator, and during the flap, try to save your perforator. We did all the possible incision for our nipple sparing mastectomy, all periareolar lateral, straight lateral, trans nipple and areola, inferior mammary. So we have a very, very good experience with all the possible incision. Sometimes you don't have choice, like in this case, the patient had previous reduction mastopexy, and we utilize this incision to do our nipple sparing mastectomy. But of course, the most cosmetical incision is the mammary crease, a little extended into the lateral aspect of the mammary crease. A little difficult to remove the upper portion of the breast that you need, of course, to do. Sometimes a little difficult to reach the medial aspect of the breast, but this is probably the most cosmetical incision, and the incision that most women would like now for the nipple sparing mastectomy. And what we learn is that usually patients who opted for nipple sparing mastectomy would like an augmentation of the breast. So it would be better to do your incision a little posterior. Other way, if you do in the real breast mammary fold, when you augmentate your breast, you may have the more visible incision scar in the anterior aspect of the breast. We have a trick when we do this incision, and the trick is to do our mastectomy in a sort of reverse way with respect to the conventional mastectomy. What does it mean? That in the conventional mastectomy, usually you do first your skin flap and then you dissect your breast from the muscle. But in this incision best is first to dissect your breast from the muscle and then do your skin flap, because it is much better, easier to remove than the breast. This is a case in which the incision is inferior lateral, 12 centimeter of incision, and after the incision we prepare the inferior little flap. You know, over here there is really not a lot of breast tissue, so you don't need to do a long inferior flap, not at all, but just a little, and arrive right away on your muscle. Yes, you can see the little inferior skin flap preparation. Not a lot of breast tissue, just subcutaneous tissue, and you can arrive right away on the muscle plane, the recto abdominis plane. Never cut, of course, the fascia of the rectus abdomini, and you can see over here. And now you can start to dissect your breast from the major pectoral muscle. It's important to identify the major pectoral muscles. Sometimes you think that is the major pectoral muscles and is the serratus, and you may really have a false plane. So this is the serratus, and the plane is just above the serratus. You need a gentle retraction, and then to continue to dissect your breast from the muscle. This retractor is excellent. It's a light retractor. With the light retractor you can better see, because the surgical exposure with this incision is not so great, especially when you are going far away from your incision, little hemostasis, and we use the clip for the hemostasis. There are some vessels of the axillary tail. This is the area that may the most bleed. And then when you arrive to the sternum, subclavicular region, lateral aspect, you and you dissect all your breast, you do your flap preparation, flap incision, and you do your flap incision, and you arrive to the nipple and areola. And so you proceed, you go all over, and you can see, so we are continuing over here to do our skin flap with the catheter without any problem. This patient has a very good subcutaneous plane. Fortunately, she doesn't bleed. Sometimes you may have more bleeding. The long tip cautery is very useful in this case, because you can really go up, you know, and see your surgical field. So we continue all over until we arrive to the areolar ducts. And then when we arrive to the retroareolar ducts, we inject some saline. We don't inject epinephrine. Someone would inject epinephrine. No, we inject just saline 10 cc retroareolar, because the saline can really create a very good plane in your retroareolar ducts. And then with your Metzenbaum, your scissor, you can divide the retroareolar ducts from the nipple and areola. This younger patient than before may bleed a little more. The bleeding is minimal. Of course, you can stop and do your hemostasis, but again, you may finish and do your hemostasis a little later. Yes, you can do your hemostasis now when you are far away from the nipple and areola. And then once the nipple and areola is dissected from the skin tissue, you can continue. We can continue with your cautery, with the retractor going up, lateral, medial, to your skin landmark, medial aspect, parasternal aspect, subclavicular aspect, and the axillary tail aspect. Very, very important to remove all the breast tissue. So once you arrive up and the skin flaps correspond to the breast flap that you did, you can divide the breast parenchyma. You can divide, you can at the certain point identify the two, yes, like this. So you identify where the breast parenchyma is still attached, and you remove all your breast tissue. And it's much easier if you use this technique than the skin breast flap first. You can see that is quite easy. The most difficult part is, of course, the preparation of your skin flap. So the hemostasis, we are almost finished in removing the last axillary tail tissue. So this is your incision, and the breast tissue is totally removed. You can do some hemostasis, and then ask your plastic surgeon to enter and do the reconstruction of the breast. This is another case, more a teaching case. Again, done by the fellow under my control. And of course, we need to teach the fellow to pay attention, because sometimes, you know, the critical part is not to see the derma. And you can see here that there is a little exposure of the derma, and this may really create a risk for the patient. So I teach the fellow with the cautery not go to the flap, the skin flap, but go to the parenchyma, retract, and the subcutaneous tissue is a little more safe. You can see over here the derma exposure that there was a little concern. Fortunately, the patient didn't have any problems. And then the same technique, removing once you did your skin flap, removing the gland from the breast tissue, from the breast. Of course, sometimes the post-op, you have some concern. You can see some dusky nipple and areola. What do we need to do? Often the situation can resolve without any problems, but you need to watch. There are some experiences using nitroglycerin, increasing the blood flow, or using the hyperbaric chamber for the patient. I did this patient last week. I saw the patient today. She's definitely much better. But what about the nitroglycerin? Well, if you use the nitroglycerin, you can have a little better outcome. And there are meta-analysis showing that the outcome it's really better. The hyperbaric chamber is controversial. We don't know exactly if the hyperbaric chamber can really help, and it doesn't seem in some studies that can really help, but the studies are with small patients. When we need to do the nipple-sparing mastectomy, of course, for risk reduction surgery in some breast cases, and when the size of the breast and the ptosis of the breast is not too much. For cancer, no clinical involvement of the nipple and areola, any size of invasive and ductal cancer, at least less than 3 centimeters, but 1 centimeter from the nipple and areola. We do frozen section on the retroareolar ducts, showing 4% of false negative result. Breast ptosis less than 4 grade. Over the years, we increased more and more our indications for nipple-sparing mastectomy, and we are doing more larger cancers, especially after the neoadjuvant chemotherapy, because we saw that the neoadjuvant chemotherapy can decrease the size, but can clean up the retroareolar possible cancer. This is a very interesting case in which after neoadjuvant chemotherapy in a triple positive breast cancer, we completed a response and we were able to do a nipple-sparing mastectomy. We are extending also more and more the indication in large breast. What do? We perform mastopexy reduction, plastic surgery, and 3 months later on, we do the nipple-sparing mastectomy. Sometimes we put a little silicone patch below the nipple and areola to better autonomize the blood flow of the nipple and areola. When the patient has a very good subcutaneous tissue, we can do the reduction, mastopexy, and nipple-sparing mastectomy all together and be able to do nipple-sparing mastectomy in very ptotic breast. But the patient has to have very good subcutaneous tissue. Otherwise, you may really have more residual tissue left behind. So I would like to conclude telling the nipple-sparing mastectomy is a little more complex than the normal mastectomy. You will need more experience, you will need a very good surgical skill, and this is very interesting, showing the workload difference when you do a nipple-sparing mastectomy versus skin-sparing mastectomy in terms of physical performance, frustration, distraction of the two procedures. So the nipple-sparing mastectomy is really something that it would take more effort, more concentration for your surgery. Thank you so much for your attention.
Thank you so much for the invitation, Mahmoud, Mohammed Al-Bashir, my friend, and Hassan Jafar. This is a great pleasure to be with you. My topic is about breast reduction in oncoplastic surgery. I will show you a step-by-step and some tricks in level 2 techniques, particularly in inferior pedicle, which is the most frequent technique that I use in my practice. I don't have conflict of interest to show here. And we have 3 great advantages with increased incorporation of oncoplastic surgery in our practice. The reduction of reoperation in breast conserving surgeries, the improvement of aesthetical results in conservative surgeries, and the reduction in mastectomy rates. But of course, it all comes with some challenges. We have 3 major global challenges in the incorporation of oncoplastic techniques in our practice. The number one is to think oncoplastically. And what I mean for this, breast is an aesthetical functional organ. Surgery needs to include aesthetics in this operation, in its philosophy. To train surgeons to be more able to perform all oncoplastic techniques, and this is a big challenge. And of course, maybe the most difficult part of our practice is to deal with patients' expectations. Quality of life depends directly on our decisions in surgery. One size does not fit all anymore. Breast surgery is now a very complex surgery. Patients want more, as Mahmoud told us, and Tibor too. But the good news is that if you master 3 techniques, I mean superior pedicle, inferior pedicle, and round block, you can solve more than 90% of your breast conserving surgery cases. Well, we will talk about inferior pedicle in a multifocal tumor. So this is a maybe more complex case. This patient is an obese patient. She's 33 years old, no family history of cancer, 3 tumors in the superior medial quadrants in the left breast with 20, 17, and 18 millimeters, invasive ductal carcinoma, luminal B. This is for mammogram, showing an heterogeneous dense pattern C, as you can see here. But the tumor in mammogram is a unique tumor, just this one. Speculated nodule in the posterior third of the superior quadrant of the left breast. And in the ultrasound, we found a spiked nodule in the superior quadrant at 12 hours. Percutaneous biopsy by ultrasound confirmed the diagnosis, moderately differentiated invasive ductal carcinoma. But on MRI, we had a surprise. 3 different tumors and some additional small foci of breast cancer. Then 17, 20, and 20 millimeters, and 18 millimeters, sorry. Then we did a demarcation of the nodules with roll and activated coal and marking the skin projection because it is important to our surgical planning. And these are the draws. Patient in his stand position in front of me, sternal notch, medial line, the inframammary fold in one side and in the other side too. And now we are going to mark the projection of the nipple and areola complex using the Pitangis manure, as you can see here. And this will be the A point, I mean, where it will be the superior part of the areola complex. I'm sorry, I will return a little bit. I'm going back, yes. From here to here, the A point to here, it's 5 centimeters. From here to here, 4. From here to here, 4 centimeters. Then this is the dome of the moschea and the medial line. the lateral line. And from this part until here, I use 7 centimeters in big breasts like this one. Then we move the patient in a lateral position and I ask her to put her arms, yes, in this part. And then from here until here, it is a big breast, as you can see. And from here until the medial part. And the other side, we do the same thing. So 4, 4, 5, 7, 7. This is the final draws. I usually put the patient initials here. I will reduce the breast. This is the patient expectation. And the tumors, 3 tumors in the superomedial quadrants of the left breast. Then we will begin the surgery with the incision and a previous marker lines. And it's important to do all the incisions in order to avoid letting this until the end of surgery. It's the areola centered in the nipple. Sorry for my head here. Then we go to all the markings. And then the radiologist did put 3 marks in the projection of the 3 tumors. And this is to plan where I will resect the breast inside these lines of oncoplastic lines. And here is my point of de-epithelialization, my border of de-epithelialization. And we will begin with the de-epithelialization part 1, leaving dermis so that we can give more firmness in the flap. As you can see here, we are beginning with de-epithelialization. We have the blue dye here. We usually mark with the blue dye and technetium, the sentinel node. So we let dermis behind in our de-epithelialization, as you can see here. Then we began with the second part of de-epithelialization, crossing the cochlears in order to achieve better countertraction with my assistance, as you can see here. Doing this maneuver, I can go in one side to other side, and the de-epithelialization is easier in this big breast like this one. And the de-epithelialization in inferior pedicle is a long de-epithelialization, as you can see in this patient. We can go in one side until the other side. So balancing the skin and using these cochlears as a counteraction against my assistance. And the end of the epithelialization, the part 3, where the skin and dermis are more adherent. In the inferior part, we will have a little more bleeding here because in the inframammary fold, the skin and dermis are more adherent. So we have more bleeding here. And it's important to remember you that the vascularization of the nipple and areola complex in the inferior pedicle does not come from here. It comes from the lateral inferior part, not from the medial part. So don't be afraid to do this in your practice. Then we will begin with the lateral quadrants of the breast, part 1. We will prepare for resection of the tumors in the superior part here, as you saw as a previous in my presentation. And we will begin with the lateral flap. This is one particular important point in this surgery, because if you let this lateral flap too thin, you can have necrosis in your surgery and maybe some delay in the beginning of radiotherapy if the patient goes direct to radiotherapy and not to chemotherapy. So this is the preparation for resection of the tumor and the preparation for the lateral flap. We go until the lateral part, and this one, because I will prepare this lateral flap, and I need to do it before it goes to here. And then I'll go until the end of my previous draws. Here, I will begin to the resection, to the dissection of the lateral flap. It's important to let about 2 centimeters in this kind of breast because she has a fatty breast. So if you let too thin here, you have problems. And we had a surprise here because we have one mark, one charcoal here. So one tumor is close to skin here. And it will be necessary to enlarge the cutaneous margin in this case, but it is not a problem. I will just remove the margin in that part. It's not, it's important to don't, to be aware to let too thin the thickness of the lateral flap. Then this will be the delimitation of the margins. One charcoal here, another one here, and the third one is here. So we will have the 3 tumors, and I will resect with this skin over this tumor in order to help, in order to guide the pathologist with the margins, and with particularly with the skin margins. So this will go with the quadrant to go to the pathologist. So we are going to remove the 3 tumors together. And here, of course, in this part, the skin is very, very thin, but this is not a problem because this part usually is not tense at the end. And then most of times we will not have a necrosis. I am more afraid of the lateral and the medial flaps. So this is not too dangerous to do when it's necessary, of course. Then we will dissect the medial margin, as you can see here. So I have tumor here, and tumor here. And we will remove all this tissue here, and removing all the tumors, and now the small foci that are between the 3 tumors. The dissection of the inferior and lateral margins. So it's not lateral, it's lateral margins. So this is the medial margin, this is the lateral margins, and we will resect everything together. And here we have the nipple and areola complex, just to guide you. And the final resection of the tumor, the tumors. Resection of the tumor, part 5, demarcation of the margins, checking with the gamma probe all the tumors, and the weight, it was 153 grams. And this is the shaving of the margins. We usually do it in oncoplastics in order to avoid compromised margins, which particularly in this case, it will be a problem. So the superior margins, the inferior margins, the medial margins, all the cavity. And this is the final defect. As you can see, it's a big defect in the superior part of the left breast. And we are now putting the clips in the cavity, which is an important part, as Mahmoud told to us in his presentation. So I put the clips in all the cavity. I put many clips. In this case, I will put 6 clips. And then we go to the axilla to do the sentinel node biopsy by the same incision. Here we have the lateral part of the breast. This is the axilla. And we can go until the axilla by this incision, because it is a big incision. We can go until the axilla without problem. Because this part, it is necessary to remove in this surgery, because we will reduce the breast. Reducing the breast, we will have less complication in radiotherapy too. And then here we find the sentinel node. We use the probe and the blue dye. So the sentinel node by the same incision. And now we are going to resect the lateral part of the inferior quadrant of the left breast. Here we went to the sentinel node, as you just saw in my presentation. Now we will resect this part, which is the lateral part. This is a component of the breast reduction. Here we will remove the lateral part. Try to avoid some dog ears, because sometimes we have some dog ear in that part. We go until the fascia, and it's necessary to have some care in the medial part, in the medial part, because here we have the vessels that we will need to be preserved, because these vessels will be important to preserve the nipple and areola, the vitality of the nipple and areola complex. Here is the point of maybe creativity, maybe the most important point, because I removed the breast from the lateral part, and I let just a small part of breast tissue here in the superior part of the left breast. Here we have the axilla, the head of the patient, and I will cut this tissue here, this breast tissue here, in order to close the defect in the medial part of the breast. So I will cut here. And as you can see, I have enough tissue to close all the defect in the upper part using the tissue from the lateral part. So that's because I love this technique. Inferior pedicle is very versatile. I can use to remove tumor in practically all quadrants except the inferior part. Now we will resect the medial quadrant here. We already resect the lateral quadrant, and I am resecting the medial quadrant, letting some breast tissue here, like wings. I have a lateral wing and a medial wings. If you let this wing here, you will not have a problem with necrosis. So this is the final dissection of the medial quadrants. This is a medial and lateral wings that will preserve the vascularization for this. So this is the lower pedicle. We can correct the defect using this. I will correct the defect in the upper part of the left breast. And I left some tissue here in order to have the viability of the vascularization of the nipple and areola complex. Well, now we will reconstruct the breast, as you can see. So I will put, the first point is the A point. I will put the A point here. These 2 points here. I put these stitches in this part because this is a long pedicle, and at least I will have more firmness in the pedicle using this stitch. Then these separated stitches. Then we will go to the contralateral breast. I will not show you the contralateral breast because it is almost the same, but not so aggressive as we went in the left breast. And this is the final result in the theater. So it is completely different from the beginning. And then, as you can see, the breasts are, I can say, very similar in terms of shape and in terms of volume. And the pathological report showed 721 grams in right breast, left breast 677 grams. Invasive ductal carcinoma, 3 tumors, and this is the measure of the tumors, 1.2 centimeters, 1.5 and 1.2. G2 margins were free, and 2 negative sentinel nodes. So what can I say to you is that Oncoplastic is a changing of attitudes. Breast is an aesthetic and functional body. It's important that rigid boundaries between surgical oncology and reconstructive surgery compromise, now we know it, that we compromise the final result for the patient. And oncoplastic surgery should not be separated from breast surgery. We cannot perform breast surgeries without having concerns about to avoid asymmetry and deformities. And postmodern breast surgeon should think oncoplastically. I wish to acknowledge my team in Brazil, our breast unit. We have all this big team together. And thank you so much for your attention. I hope that I wrote well this year. I don't know. It is thank you for all of us, all of you, and now we can discuss.
Very well written, Cicero. Okay, thank you very much, Cicero. I would like all the panelists to join us and for a Q&A session. So I hope that Virgilio is on the, here he is. Dr. Al-Bashir, will you be on?
Yes, I will go through the questions for you and ask the speakers.
Don't worry about it. I'll go through the question, but I will have you as part of the panelists so you could answer the question as if you were Tibor. I have already made some list of questions here based on what we have. First, I have not received any question, but I just received a question for Chichiro, which is great. So let me first go about a question that had started in the beginning is how far can we use, how far a tumor could be from the nipple areola complex to which we could apply a round block or a dome mastopexy. So why don't we start with you, Mohammed? You know, how far, what is the limit for a tumor distance from the nipple areola complex to which you could apply a donut mastopexy or a dome mastopexy?
Well, I think the nice thing about donut mastopexy, it gives you, it's like the door to, with the donut mastopexy, you basically have an open door to the whole breast. So I'm not sure you have any limit to what you want to do. As all the speakers mentioned clearly, that it is suitable for all tumors in all quadrants, except obviously the retroareolar or central tumors. But I'm not aware of any distance, and that's why it's a great approach.
I fully agree with Mohammed. I don't think we have any limitation of the distance. With this approach, you could go all the way up to the neck. I think for the dome and crescent mastopexy, I try not to do a lower quadrant lesion. If you have a lower quadrant lesion, the dome mastopexy does not work. I usually prefer to use a donut mastopexy. Just to make a little point clear that what Dr. Urban was saying about doing the donut in a form of an ellipse, I would like to share my screen just to give you a little bit of historical background about the donut mastopexy, because it's quite important to have that. So give me a second and allow me to share that screen. Now, the donut mastopexy was first. So the donut mastopexy was originally designed by Louis Benelli, and then it later became as a round block or donut mastopexy. Louis Benelli described this technique in this form. And if you could see it, the original description of the paper that was published, I think in the 80s, is you have an incision around the nipple areola, and it was a teardrop shape surrounding it, exactly the way Dr. Urban was describing to you. The point A is the highest point at which the areola is going to be. The point B is the distance from the areola to the inframammary line. And point C and D is the amount of skin tissue that you want to take out to tighten the breast. This is how it was designed. Later, it became like a donut shape, which is the way to do it. Most people tend to do it, but you could apply it in any way you want. You do not need to be restricted to a donut. Now, the second question about the donut is how to close this skin to bring it to the areolar edge. And they were talking about the use of absorbable or non-absorbable suture. Mohammed, what do you use as a suture for that?
Well, most of the time I use actually PDS, absorbable, but long-term absorbable suture. But I also have used Vicryl short absorbable suture. I don't remember, I think I only used non-absorbable only once. But I lifted to the outside and I took it out after 4 weeks, 4 to 6 weeks. But most of the time nowadays I use actually PDS, so I avoid the knot outside.
Chichiro, what do you use as a suture?
I use non-absorptive suture. In the beginning, I used to use PDS or monofrill, but I changed my practice because I think that the scars are much better without PDS or monocril. And I copied this from plastic surgeons in Brazil, most of them using aesthetic surgery mononylon. And believe me, it's much better.
I tend to use Gore-Tex suture. I use 3.0 or 4.0 Gore-Tex suture. They're very soft and they're not as obvious as the nylon or other type of sutures. And as I said, I bury the knot. And I learned this technique also from my plastic surgery colleagues and during my plastic surgery training. Okay, there are other questions about, someone had asked me a question, if the tumor is positive for the anterior margin, what shall we do when we are doing a donut or a crescent? Mohammed?
Great question.
Well, you can always have an extension to include the skin on that part if you think it's too close. And that's the nice thing about donut mastopexy. You can basically do any radial extension, but that's only if you think it's really going to be positive and you can't get beyond it, over it, I should say.
Chichiro?
I want to show you one draw in this way. That's a great question because sometimes you have, for example, a situation like this. Can you see? So you can resect this part and close the defect together with the round lock or with the donut, if you prefer. At the end, you have a scar like this. And it is not a problem in terms of the position of the nipple and areola complex, because as you did the de-epithelialization of the nipple and areola complex, the nipple and areola complex will be in the right side. If you don't do it, just remove the quadrant and remove the skin over the tumor, you will have the classical quadrantectomy result. Yes, like this.
So this is what I wanted to show also that you could do. Someone has talked about the modification of these, of the donut. And these are the modification that Chichiro is talking about. You could have them in any areas. I think the trick in the person who's performing the surgery is to review the image of the tumor. And once you review the image of the tumor, looking at the mammogram, the sonogram, and if you have an MRI, also having that, and ahead of time, you could plan to excise the overlying skin. I have never done it, but I always thought about it, that in case I have an unanticipated positive margin, what shall I do? I don't know if any of you have done it. In my mind, if I have to do that, which I've never faced it yet, but I've been preparing for it in case it's going to happen, I'll go back to the operating room, take down everything, and re-excise the area and re-close it. That would make it a little bit better. I have never done it technically yet, but in my head, if I face that situation, I may consider that technical part. All right, I'll stop sharing the, and now we have other question that coming from the audience. Some people have asked, do you use a local anesthesia with epinephrine? I do not use epinephrine. I think one of the problem of epinephrine that it will stop the bleeding intraoperatively and you will not see it, and so you cannot coagulate it. I would like to see the bleeding and I would like to coagulate it. I strongly recommend not using adrenaline. Now, Virgilio, when you are injecting for the nipple sparing mastectomy, you inject saline for tumescence. Do you add adrenaline to it?
No, never. The reason is when you take time to do your dissection of the retroareolar ducts, but we are quite fast, and then we inject just before to do the dissection of the retroareolar ducts. Of course, if you inject at the beginning, when you start the surgery, at the time you are over there, the tumescent doesn't work, and you need to inject epinephrine. Other way, we don't need to inject epinephrine if we do right away.
Teacher or Mohammed, could you comment on your nipple sparing? Do you inject saline or epinephrine, or you just do it without any injection?
I don't. No, I don't.
And I don't inject at all in the breast. I actually give my own medial pectoral nerve block intra-op. If I'm doing a sentinel, at the end of the sentinel lymph node, I give 10 ml of the long-acting anesthesia near the medial pectoral nerve. And if I'm not doing any axillary surgery, if I have a good exposure to the muscles later, I give it later or percutaneously. And I have found it to be very effective for post-operative control.
So there's a question. Go ahead.
Sorry. What we are doing now in nipple sparing mastectomy, just to add something, is we are doing the nipple sparing mastectomy by the inframammary fold, as Virgilio showed us, but we are putting the implant in the pre-pack area without ADM, without any mesh. Just put the direct implant in the pre-pack area. And we are waiting for the publication of a paper with 280 mastectomies, which we are doing in this way. And our surprise is that we are having less capsular contracture than when we are putting the implant behind the pectoralis major, even in cases where patients are irradiated. And another surprise using this approach is that we are having less rippling than we thought in the beginning, because rippling could be a problem when we just put the implant in the pre-pack zone. And we are very, very happy with this new approach in our practice. Nowadays, we do it in more than 90% of our cases.
Great, we'll work for your paper. Other question for Virgilio. What is the thickness of the nipple areola complex that you like to have?
It depends how much subcutaneous tissue the patient has, but usually I prefer to cord the nipple and to remove the male ducts. 3 millimeters is usually a good flap. And 3 millimeter means that you would remove 90% of your male ducts, retroareolar ducts, and you would keep about 80% of your blood supply. So 3 millimeter is a good, in my opinion, is a good balance between the removal of the ducts and the good blood supply. 2 is too much. 2 millimeter is you can really reduce your blood flow and is a little risky.
A question for Virgilio also. If you have DCIS present with nipple discharge, serous discharge, questionable subareolar duct involvement, can you perform a nipple-sparing mastectomy?
And this is a very good question. So when we had the consensus meeting in Basel, Switzerland, about a nipple-sparing mastectomy, we thought that the nipple discharge is not a contraindication for nipple-sparing mastectomy, but of course it depends on the discharge. because if you have bloody nipples discharge and microcalcifications below the nipple and the areola, or involvement of DCIS, when you do your frozen section during surgery and you see DCIS, no, I think we prefer to remove the nipple and the areola, because sooner or later the patient would have a relapse, and of course is risky for the patient. But if you have a nipple discharge and you may have only papillomas, or you may have ductal ectasia, I think you can do uniposperic mastectomy.
Okay, there are a few questions. One for Dr. Cicero, and the question is, how do you avoid bottoming out in the inferior pedicle reduction?
Yeah, putting that stitches that I showed you, we can put 1 or 2 stitches between the inferior pedicle and the dermis, or some colleagues just put some stitches in the inferior pedicle in order to try to avoid this kind of complication. But it is not that common. It is less frequent than we thought in the beginning. It's not that common for big breasts, of course, but I just put 1 stitch as I showed in my video.
So we have another question that the indication for donut and crescent mastopexy are almost the same. So why go for with donut if we can resect an upper tumor by crescent? Is there any special indication that prioritizes donut over crescent? Mohammed?
Well, I haven't done crescent, but I'm in favor of the donut, especially if there is moderate ptosis. And also gives you a better exposure, in my opinion, than a crescent, but I haven't done that many crescent. And I feel if you can do a donut, you really don't need to do a crescent, in my opinion.
What I would like to answer that question is, the donut is a bit more complex operation and you need to be well trained and comfortable doing it. The crescent is a much easier operation, a much quicker operation. I tend to favor doing the least possible. If I could do an upper quadrant with a crescent, I'll go ahead and get it done. In the lower quadrant, I invariably go for a donut mastopexy. Now, please remember that a lot of the patients are elderly and you want to get them out of the OR very quickly, and you don't want to keep them there too long. Doing a crescent mastopexy usually adds probably 20 to 25 minutes. I find the donut adds a little bit more to that, although when you develop your technique, it becomes quicker and you can tend to do it. So whatever your level of comfort with, if you have a young patient, you want to do a little bit better mastopexy, you tend to do the donut. If you're comfortable doing the crescent, just go ahead to do a crescent. One drawback of the donut, which I find, and that's why I try to avoid it, you lose projection of the breast. And if you do it routinely, you may end up, because the skin tends to pull the envelope of the breast and there's a loss of projection. That's why I tend to favor the crescent for that specific point of view. However, whatever you're comfortable with, you can go ahead and do. Cicero, you need to say something.
Yes, that's a great question. Very interesting question, because yes, I agree with you and Mohammed. Yeah, that's great point. But there is another point that it's important to have here. When you do a crescent mastopexy, most of times you do not have difference between one breast and another. When you do, for example, a round block, you modify the shape of the areola. And this patient will need, if you have a better result, a contralateral surgery. So not in all cases, of course, but If you have a patient that don't want to touch in the other breast and just have to remove the tumor and a fast surgery in a good way, crescent is perfect. If the tumor is in the inferior part, as Mahmoud told us, it's important to maybe do the round lock, but thinking that you have different shapes of the areola, nipple and areola complex.
Okay, now question to Virgilio, which I think he answered that question. How frequently you get nipple necrosis?
Again, we need to differentiate the total necrosis, the partial necrosis, just an epidermolysis of the superficial skin layers. I would say the total necrosis is about 1%. 1%. The partial 2 out of 3 is about 1.5%. In total, I would say 2-3% of necrosis in which you may lose part of the total nipple. But less now.
So I have a question addressed about the crescent. Do we get retraction of the nipple towards the upper pole after radiotherapy? Absolutely not. If you design it well, it's actually a beautiful result. And I have shown you the picture of the patient 3 years out. She has a perfect cosmetic result. I have never seen a nipple retraction. Now, if you do not repair the defect underlying the nipple areola and you leave it open, then there may be a tendency of the retraction of the nipple areola complex. Now, there is question to Virgilio. Is there still thinking that you should not core the nipple? Is coring the nipple obsolete now? Do you core it or don't you not core it?
I prefer to core the nipple because this is the practice that I do, that everyone does at Memorial. We don't want to leave a breast tissue. In a slides that I presented, there was this milky discharge after the delivery of a baby. We are doing more and more young women, BRCA patients. They come to see us at 25, they have a bilateral mastectomy, and then they get pregnant, they have children. And the last thing that you need is to have this milk, this discharge, because it means that you didn't remove the milk, the retroareolar ducts. I can understand in a 50, 60, the retroareolar tissue may never get cancer, but in these young BRCA positive patients, if you don't remove all the breast tissue, and Mahmoud may say is impossible, and I agree, but if you don't attempt to remove the most part of the breast tissue, sooner or later they will get breast cancer.
Mohammed, what do you do?
Well, I take it case to case based on where the tumor is. Even the thickness of the nipple areola regarding that question, I don't think there is really a one size again fits all. So based on the patient, what type of tumor I'm dealing with, is it prophylactic or not prophylactic, and so forth. So I like actually to invert the nipple and make sure that most of the ducts are cleaned. And also the areolar part, I like to see the smooth muscle part of it. And I can see actually most of the time the small capillaries and vessels in it. And if I don't feel anything, I'm really happy with. So I just inspect it visual, and I don't go by 3 millimeter or 2 millimeter. And again, from case to case. If I'm dealing with DCIS, obviously, going to the nipple, I will be more and more careful on these cases. to shave as much as possible and to core the nipple to avoid positive margin.
Chichiro?
I agree with Mohammed. I think that we don't have a standard, and it is individual. The anatomy is completely different from a young patient from, for example, for an older and fatty patient. So it's necessary to go case by case, and I don't have a magic number.
I tend to core the nipple. I fully agree with Virgilio. We are going there to do an oncologic operation, particularly when you're doing a prophylactic, and particularly if it's a patient who is a BRCA mutation carrier, you want to minimize the amount of breast tissue. As Dr. Sakini said, there's no way you could take all the breast tissue by leaving the nipple behind, but at least you could minimize the amount. Now, by coring the nipple, you increase the risk of nipple necrosis if you don't do it carefully. So you need to learn how to do it. Now, one more question for Chichiro. And the question is, what is the optimal width of the inferior pedicle in an inferior pedicle reduction?
For an inferior pedicle reduction, there is no limit. In the past, we sometimes tend to do it in a different way. For example, with a big breast for 2 kilograms of reduction, for example, it was necessary to do a removing nipple and areola complex and do a graft. But nowadays, I don't do it anymore. Inferior pedicle is very safe, and we can do big reductions. Maybe the bigger reduction that I did in my life was 202 2 kilograms and 200 in each breast, without nipple and areola necrosis. So it is possible to do a surgery, letting the 2 wings that I show you. So it's safer. With inferior, there's one thing that it's very interesting with the inferior pedicle. Inferior pedicle seems more complex than superior pedicle, and in fact it is. But the risk of complication in this inferior pedicle is much lower than superior pedicle. For example, in inferior pedicle, I never had a nipple and areola necrosis, but with superior pedicle, I had some few cases. But this is this is a disaster. So inferior pedicle is very safe, very safe.
Now, I got a question that I'm not clear what it means, but it says, is a round block with lateral extension incision okay for cosmetically for nipple sparing mastectomy? I think what the person is saying, maybe you could take a little bit of the skin laterally and leave the dermal flap on the nipple areola, leave the nipple areola on the dermal flap. Virgilio, did you get that question? Is round block with lateral extension okay for cosmetically? Perhaps the person should re-explain that question. Anyway, let's move on. I'm
afraid.
Go ahead.
I'm afraid, Mahmoud, to go to periareolar incisions and to round block incision when I do, for example, nipple sparing mastectomies. I think that we have more nipple and areola necrosis in this case. I don't know if it is the same opinion that you have in your practice, or maybe Virgilio, Mohammed. No, I prefer to do inframammary crease nowadays.
Go ahead.
Yes, I didn't understand. I didn't understand the question because I never did. Because I think it will be very difficult, because again, you need to remove tissue, and unless the patient has an incredible subcutaneous tissue, other way you cannot do. And the inframammary is probably the best from the cosmetic point of view, and a little more difficult, of course. But I'm a little concerned to do an incision around the nipple and the areola, and then the necrosis. Everything can be done, but of course, again, the priority is to try to remove as much as possible breast tissue.
I think this is a very important tone. I personally avoid any incision around the areola when I'm doing a nipple sparing. I try to keep the skin attached to the nipple as much as I can. Even when I do the lateral incision, I try to stay a little bit away from the areola when I do a lateral incision. Mohammed, what's your approach to nipple sparing?
Well, I'm like you. I do mainly radial, lateral, or inframammary based on the breast size. But for the, I think the person who asked the question, I know Dr. Kifah at the London Breast Institute does periareolar with lateral extension based on where the tumor is. And he has published that with a low rate of nipple necrosis. Although in my humble experience, just like you, I like to avoid any incision around the areola because of the risk of ischemia. So actually my personal favorite incision is lateral in those large size breasts or inframammary in the smaller size breast. But it has been published, I know there, definitely from the London Breast Institute by Dr. Kifah.
So I think there's time for one more question. I think it's a very important question. Regarding multifocal tumor, which one is better, nipple sparing mastectomy or round block? Why don't we start with Virgilio?
Of course, it depends on the size. It depends on the size of the breast. If you have a small size, of course, nipple sparing is definitely the best. But we are doing more and more medium size. It depends on the doses, but the size is important. And of course, if I can, I do nipple sparing. But if the patient is very, the breast big and ptotic, probably the other approach is better. Once, of course, you can find negative margins, and once the multicentricity is not, so far away.
Mohammed?
Well, this is really, it's from a case to case. If it's multifocal in the same quadrant and you think you can get it through a donut mastopexy and patient has moderate doses, may or may not be candidate for nipple sparing. Even if they are in different quadrants, you probably can do separate excisions through the donut, the round block, if you have enough breast tissue, and mobilize the parenchymal breast tissue in each side. So again, it's a technical thing. Again, it will depend on the patient and from case to case, but both can be feasible.
Chichiro?
Depends. Big breasts are gonna go do inferior pedicle, for example, or superior pedicle. And for medium-sized breasts, maybe, or small-sized breasts, if it is possible, I will go to a round block. And nipple sparing, just if the result in the breast conserving surgery using oncoplastic techniques will not have a good result. I think that it's much better most of times if you can preserve the breast.
So let me answer it this way. There's a reason why we call it oncoplastic. And we started with the term onco because this is an oncologic operation. This is not a plastic surgery procedure. First and foremost, you need to resect the tumor and make sure you get the tumor in the best oncologic way possible. Then you apply your plastic surgery technique to enhance or improve the appearance or fix or repair the breast or rebuild the breast. So if you think you can keep the breast, clearly the final good cosmetic result that is far superior to a mastectomy, but you cannot compromise on your oncologic procedure. I would like to stop here because of the sake of time, and I would like to take this opportunity to thank all my colleagues who joined us and to thank the attendee for these great questions. I hope you have learned a lot. Thank you, everybody. and have a good day.
Thank you.
Thank you. Thank you to everyone.
Thank you all.
You, teacher.
Good.
Bye.
Ciao, Virgilio.
Thank you, everyone.
Bye.
Bye.
Ciao.
Bye, Mohammed.